This is Michael Altos recording the second lecture, IV Anesthetics, Induction Agents and Sedatives, Part 3. We're going to shift gears now from our IV induction agents to benzodiazepines. There are a very large number of different benzodiazepines, and I've put some of the names here, not for you to memorize, but so you can start to become familiar with these names. And we'll do this throughout the year, so that you can see these names, both the generic names and the brand names. So you'll see all the generic names end in AM, lorazepam, diazepam, midazolam, and the brand names Ativan, Valium, Versed, and there are many others. Also flumazenil, which we'll talk about in a little bit, also known as romazicon. That's the antidote to benzodiazepines, and it itself is also a benzodiazepine. These drugs all enhance the inhibitory neurotransmitters, specifically the GABA neurotransmitters, in the cerebral cortex. So they do work in a similar way to some of our other drugs like propofol and etomidate. Some of these are insoluble in water and they're dissolved in propylene glycol. Midazolam, which we use most often, is an aqueous solution in the vial. The benzodiazepines can be given by a wide variety of different routes of administration: intravascular or intramuscular, orally, nasally, sublingually. If you want to put somebody to sleep with benzodiazepines, you would need to use IV administration. But it's really a poor choice. First of all, you would need a ton of the drug, and as a result, the patient would wake up very, very slowly. These drugs have a significant hepatic first pass effect, so we expect that you'll need a lot more drug when you administer orally than when you administer IV. The drug becomes pretty lipid soluble in the body, and so it acts quickly and redistributes quickly. The drugs are protein bound, and as you've probably seen in your own practice, when you give midazolam, the onset of action is really in about 30 to 60 seconds, and the peak effect occurs in about 5 minutes. So if you're trying to sedate somebody, you probably wouldn't want to give a dose every couple minutes because you'll get some dose stacking. And the duration of effect, at least for the first few doses, is usually about 15 to 80 minutes, depending on the drug we're using. Obviously, if you give a lot of doses, you'll start to have saturation of the peripheral compartments. These drugs are biotransformed by the cytochrome P450 family, specifically the 3A4 subfamily. Some of these drugs have low hepatic extraction, while others like midazolam have higher hepatic extraction. And they're excreted in the urine. The dose for midazolam is published at about 0.04 to 0.08 milligrams per kilogram, whether it's IV or IM. If you think about it, that's 4 of midazolam for a 100 kilogram person, which may be more than you're used to using, but if a patient were actually truly anxious going back to the OR, you probably wouldn't hesitate to give 4 of midazolam. So I think these values are reasonable. If you're giving it orally, you may need almost 10 times as much, 0.4 to 0.8 milligrams per kilogram orally. Induction of anesthesia, as we said, this is not recommended, but about 0.1 to 0.3 milligrams per kilogram IV. So we're talking like 10 to 30 milligram doses of midazolam IV. And it can be run as an infusion, although you won't see that done very much in the operating room, at about 0.02 to 0.1 milligrams per kilogram per hour. Definitely use very little doses of benzodiazepines in elderly patients. The effects on the cardiovascular system are pretty minimal with benzodiazepines. We don't see a lot of change in heart rate or blood pressure, which is nice. When you give patients benzodiazepines, they do have a small decrease in their hypercapnic drive, which means that they'll tolerate a higher CO2 level before it stimulates their breathing. And this is especially true when given together with other medications like fentanyl or Dilaudid or propofol. In the brain, like most of our other drugs, benzodiazepines will decrease ICP and cerebral blood flow as well as cerebral metabolic oxygen consumption, but not as extreme as barbiturates and some of our other drugs. You can't get to burst suppression or anything like that. Benzos do cause amnesia, and I should remind you that it's an anterograde amnesia. From the time of administration forward, that's the kind of amnesia that you'll have. It can't erase old memories of things that happened in the recent past. But what I would say is, while there's no drug that causes retrograde amnesia, it's possible that events that happened very recently, which are still in your short-term memory, benzodiazepines might block their conversion to long-term memory. And so patients may have some amnesia of things that happened prior to getting the benzodiazepines. The drug is excellent for anxiety. It's a good anti-seizure drug. All of them are. They're muscle relaxants. Patients can become dependent on benzodiazepines. And dependence is defined as any sort of physical or psychological symptom after you reduce the dose. So whether you get a headache, a physical headache because you haven't had your caffeine today, or whether you just get cravings because you haven't had your cigarette today, these are both examples of dependence. And the same is true for benzodiazepines. People can have withdrawal symptoms. They can become irritable or tremulous or they can become insomniac. And actually, benzodiazepine withdrawal can be fatal if patients are very dependent upon them. It's similar to alcohol withdrawal, which can also be fatal in its most severe instances. As we said before, these drugs are synergistic with other drugs, which means that if the benzodiazepine is given together with a volatile anesthetic or an opioid or ethanol, barbiturates, or any other drug, you can see exaggerated effects of the medication. Benzodiazepines can be reversed. So there is an antagonist which will bind competitively for the benzodiazepines receptor, and that drug is called flumazenil or romazicon. It has a very high affinity for the receptor, and it has basically no activity. So it's really an antagonist, but it is actually a benzodiazepine. The dose of flumazenil is 0.01 milligrams per kilogram, up to a 0.2 milligram IV bolus, and you can repeat that every minute up to 5 doses, which is a total of a milligram, which I think is the amount in a single vial. Now remember that patients who get a long-acting benzodiazepine and then get reversed by a short-acting flumazenil may need a repeat dose as they resedate again. So every 20 minutes you need to reevaluate these patients to make sure they aren't becoming resedated. You cannot reverse volatile anesthetics with flumazenil. It won't work. And if a patient is dependent upon benzodiazepines and you give them flumazenil, you could induce withdrawal symptoms. So we want to be careful about that. This is a good time to jot down any questions you have for class or for emailing me privately. The next sedation drug I'd like to discuss is Dexmedetomidine, also known as Precedex. This is a totally different class of drug. It's actually an alpha-2 receptor agonist, and we're going to talk about this kind of drug and the whole autonomic nervous system later on in the semester. But for now, we'll just suffice to say that it's an alpha-2 receptor agonist. It's a lot like clonidine, which is also an alpha receptor agonist, but Precedex is even more alpha-2 specific. It was on label originally for sedation of ICU patients, but has been used for anxiolysis, for MAC anesthesia, for an adjuvant to general anesthesia, and for sedation during awake intubation. So it is a very interesting and very effective drug. Dexmedetomidine is typically dosed at 0.2 to 0.7 micrograms per kilogram per hour. Often a loading dose is run first, or some people just start with the maintenance dose and let it build up over time. The book says that you can run total IV anesthesia with dexmedetomidine at a dose of 5 to 10 micrograms per kilogram per hour. I've never seen anybody do this, and I think that it might take a really long time for a patient to wake up from this kind of anesthetic, so I would never try it. The effects of dexmedetomidine are notable for hypotension and bradycardia, so I would avoid this drug in a patient who has any sort of cardiac dysrhythmias, especially bradycardia, and patients who have low blood pressure. It has almost no effects on the respiratory system, so it preserves respiration, and what you end up getting is this calm sedation with rousability, where the patient is sleeping, they're resting and they're relaxed, they're not anxious, they actually have some analgesia, but they will rouse easily when you speak to them. So it's an excellent drug for MAC anesthesia under certain circumstances. There are people who will use it together with a general anesthetic to reduce your MAC of volatile anesthetics. I haven't done that personally, although I've seen it done. The drug is expensive, and so I wouldn't normally choose to do that. I also point out that the drug is really slow to metabolize. It hangs around for a while. So you do have prolonged recovery profiles. And for that reason, I don't use this drug very much, although I found it to be excellent in the ICU for sedating patients on the ventilator, especially alcoholic patients who are very wild. So that's very useful. I use it in awake craniotomies, and I do use dexmedetomidine sometimes for management of awake intubation. We'll stop the lecture here, and if you have any questions, please bring them to class, or feel free to contact me at any time.